everyone. Let me introduce today's case. Okay, today's case is 60 gentleman. He has a effort angina, and he received the coronary angiography 2012 this October. He had a LAD stenosis and RCA CTO. So we already fixed the LAD stenosis, and today is where our targeted mid-right coronary artery CTOs. So this is the CT findings. So the patient has a good collateral from the left coronary system to the distal RCA. So you can see the very big calcium before the bifurcation PD and AB branch. So collateral flow is come up to the almost there. And CTO started from the middle of the RCA. So the in the multi-slice CT findings estimated the occlusion length in 4 centimeters. So let me show the coronary angiogram. So this is a right coronary artery angiogram from the LAO view. So maybe you can see the CTO in the middle of the RCA. So from the RAO caudal view, you can understand more clearly the morphology of the proximal edge of the RCA. So here is two branch, big one and small one. Now from the small one, CTO is started. Now also you can see there's some proximal stenosis there. So in terms of the collateral flow, this is angiogram with the left coronary system. There you can see the severe stenosis, proximal LAD, we already fixed. And then you can see there's some septal channel connection, but not clear, to the PD branch. So we already checked the chip injection when we fixed the LAD stenosis. So you can see there is 1, 2, 3, 4, or 5 of the septal branch. We checked everyone, but the issue of this case, connection through the septal branch is not promising. Okay, I can show you. This is a checked of the AC branch. Of course, from the AC branch, there is some connection to the AB branch, but maybe it's not interventional. So I checked it. This is the third septal. So third septal is not promising, and this is second. Second is also, we can see some connection to the PD branch, but it's not so very tiny, and we are not sure the exact morphology of this channel. Usually this kind of the small septal channel, there are so many bifurcation in there, so maybe selection is usually very difficult. So this is a very issue of this case. So literally the chance is not so much for this case. This is the first septal. First septal is also connection is misty. So today's we of course studied from the integrated approach. CTO length is 40 millimeters. That is not so short, but from the multi-slice CD findings, vessel is very big and not so much calcified. So, and also the distal end of the CTO, we can see the very big calcium in both multi-slice CD and angiogram. So we have a target to integrate wiring. So that I want to study the integrated approach today. So if the integrated approach is failed, so we should try to the retrograde approach through the septal channel. Okay, we can start it now. Okay, this is today's simultaneous shot. Our system for integrate I use the 8 French plus 1.5. And for left coronary system, super backup catheter, 3.5. And left coronary system guiding is pressure is very easy to damping. So that I put one wire to the LED, and I control the position of the left coronary system to avoid the damping of the pressure. So now the pressure is fine. So we checked the left undershot from the left coronary system and chip injection from the undergraduate microcatheter catheter. So in the angiogram, so we can see the proximal calc very clearly. Just distal of the very small RV branch, maybe CTO will be started. But retrograde short. So distal cap of the CTO is ambiguous, but maybe around the distal calcification, collateral healing is we can see. So maybe CTO end of this case is before the PDA bifurcation. So of course, I want to study from the undergrad guide wiring. So in a multi-thread CT findings, vessel size is very big. And the proximal part of the CTO is not so hard. So I want to study from the polymer jacket tapered wire. This is XTA. So I checked the chip injection again, more distal, but we cannot see any channel inside the CTO. So I want to penetrate the proximal cap by the XTA. Okay, XTA doesn't work well, so I changed to the next one.これね、ちょっとそっか、これ普通のあれようにした。そしたらちょっとチップインジェクションにして上で。最後のチップインジェクション。いや、入ってないでしょ。入ったかな。ちょっと入った。これ枝じゃね。ちょっとチップインジェクションに戻し。違うな。 いえ、これは違うと。意外と硬い。の方。So we can see the qualification inside of the CTO. So we can use a landmark, this calcium. ちょっと入ったっぽいな。だけど一応シンクロしてるから。So wire is synchronized hard motion.これでいいんじゃないの。とりあえずつくにはつけた。チップインジェクションに戻ってみてくれる。So, check the chip injection. So maybe next one is could penetrate the proximal cap of the CTO now. So I want to use the XTA again, because this is a very long CTO. Even though that we can see the qualification, we can use the qualification as landmark, but the long CTO guidewire is sometimes very risky, because this wire has a good penetration efficiency. So that's meaning that we can make it vessel perforation very easily. So the softer one is better for the safety. Okay, store fluoro. Start. Okay, now XTA is advanced a little bit more. Maybe tip of the wire seems to be inside the CTO. So there is no resistance is there. Okay, store. Okay, try to advance the microcast caliber. じゃあミラクルネオ 3g. So XTA is a chip cannot be controlled well. I think that there is a hard region is there. So I want to escalate the wire chip. If we can see that very good target, I want to use the Gaia family, but still we have a very long journey. So my selection is the Miracle Neo 3g. CT あれをコーダルでどんな走行か見せてくれる？うん。CT のアンジオグラフィックビュー。あ、いい感じ。あれこれあれよ。もう almost straight. Could you see the LO view, right? LO view 見せて。まあ悪くはない。アンカーシュ。シュンブルプリス。We need to the backup force. So yes, I inserted the wire to the R branch and then the balloon anchoring for making the backup force. So after making the balloon backup, you can push the caravel. Now is the chip of the caravel inside the CTO like this. So that means we can have a more backup force for integrated wiring. But wire control is not so easy.こっち行きたいよね。こっち行っていいんだな。多分。うん、じゃああれをコーダール30、30。So it's very difficult to navigate the wire along with the vessel course because even though we can see some spot clarification inside the CTO, but the real vessel course is very difficult to identify. So that is a very difficult issue about the long CTO segment. So now I changed to the polymer jacket 3-gram wire Gladius. So in this situation, for the integrated approach, guidewire, I think the guidewire is a little bit risky. As I already mentioned, the guidewire's penetration efficiency is very good, so sometimes very easy to make it perforation. This kind of the case. 進まないな。
うん、なんか良さそう。手前の代わりがいい感じ。うん。はい、これ出してください。
普通のエリオの方が見やすいかな。で、
ガイドが。
うん、ちらっとちょうだい。ガイド見してガイド。
全
So gladius can be advanced along with the vessel course. So at least wire chip inside the vessel, not outside. So I checked the contralateral injection like this. So now you can see the very big distal two lumen before the PDAV bifurcation right here. And in the aerial view is the chip of the guide wire. Not so position is not so bad. And also aerial caudal two lumen is a little bit backside. So anyway, this wire the works for the as a integrated preparation. So I continue the integrated wiring a little bit more.結構なんか進むんだよな。あ、進む。投資保存して。So this is the last shot of the contralateral injection. And then next please. Next please. Next. Next. So I advanced the gladius a little bit more. So now I'm not sure that you can see, but I could navigate the gladius a little bit backside in aerial caudal view. And also in aerial view, its wire position is not so bad. So anyway, the distal two lumen located the back side and the bottom side of the coronary artery, inside the coronary artery. So now the position is not so bad. I want to check the contralateral injection. Okay? Yes. So let's go. So I advanced the calabar to the distal. ちょっと待ってよ、もうちょっと引っ張って先生。はい。ああ、いかねえよ、ここで。Okay, okay. So wire this position is not so bad, but still I could not get the distal two lumen by the gladius. So I changed to the microcaster from the calabar to the Corsair Pro. Still we have a chance to penetrate this region by the integrated approach alone. Because if we have a very good collateral channel, so I immediately move to the retrograde approach. That is more smart procedure, but this case doesn't have a promising collateral channel from the septal. Okay. ちょっと引っ張っていけよ。ちょっとだけね。はい。 なんかワイヤー進んだ蔵にあるし
あ、ゾエザイ。
左
ちょっと待って
いやーそういやゾエ見して上のここにしか行かない他のとこに行きゃいいけどシチュエーションを悪くするだけのような気がするけどいやーどうだろうこれは抜けたっぽいな表情どうしてまだ待ってよまだ待ってよはい取ってはいうん通ってるねうん大丈夫だなよいしょOkay, now maybe Gradius, fortunately, could be penetrated distal cab. Okay. So this shot is very important because in this contralateral shot, distal cap of this CTO is very ambiguous. So that means there's some flow or some soft tissue in the most distal of the CTO segment. So that's why I continue to the antegrade wiring by the Gradius. Next, please. So I put the microcaster and then push the Gradius gradually. So I could get a very small branch in the distal end of the CTO. The finally Corsair, it could be advanced the distal to lumen. But I could not see the backflow, so I changed to the wire from the Gradius to the XTL, very soft one. Next please. Next please. Next please. Next please. So this is the XTL. The XTL could be advanced. Firstly, there's very small branch right here, and then finally I could get the every branch. So I try to advance the Corsair. Well, いいよねここで。もうちょっと抜いときたい。いやいいよ。じゃあシオンブルー、シオンブルー、ニューシオンブルー、プリーズ。Okay, now we can see the backflow. Now let's check the chip injection. Okay, so we can get the distal to lumen now. So in the CTO intervention, radiation exposure is one of the very big issue in the usual case. Even though the angio machine, the quality is very good, nice. Nowadays, this machine is Canon is a newest one. This Alpinix is can make it a very good image quality and then the very less radiation exposure. And also this system has a dose tracking system. So maybe you can see the screen on the screen. Some blue or green, the color images. So that is a real dose tracking on the skin of the patients. So today we already put the almost 1.2 milligrade, 1.2 grade, right? Very less. So even though the procedure time is a little bit very long, maybe yes. So the procedure time almost 1.5 hours. But even though this kind of the very long procedure, radiation dose, real radiation dose of the patient's skin is very less with this machine. So this is a very good advantage point. And also we can see the risk of the radiation exposure of the patient directly on this kind of the dose tracking system. And also we can check so as already mentioned, we can see the skin dose of the radiation. So now in a LAO view, a little bit high radiation exposure we can see. So we can save the lateral radiation lateral shot, and then we can change to the projection to prevent the radiation dermatitis of the patient. Now is that we change the projection, the front of the areocranial, and lateral is areocranial. So the view is fine. We can continue the procedure by these projections. So this kind of the strategy is very important to prevent the issue of the patient skin trouble. この辺。はいはい。Okay.
あ、ごめん。
はいはい。This is a 1.5 balloon. So 15. 15. 15. あ、そうだ、スポットライト今つけてくれる？ And also this machine has another system for reducing the radiation exposure, spotlight. So now you can see some square, the right square inside in the angiogram. So this image can make it maybe the machine is just put a filter to the maybe FPD, and then outside of the square is a radiation exposure is very less, but inside is we can see the balloon or something is very clearly. Okay. Okay. よし。ちょっとワイヤーのチップ見して。ワイヤーのチップそうそうそうそうそう。Here is the distal end of the CDO. So we can see some space in the 12 o'clock. So anyway, the distal end of the not so hard. So this is real CDO. So wire is inside the two lumen, but here is the attenuation plug. So yes, vessel is very big. Here is the proximal cap, around the proximal cap of the CTO. Now that you can see the RB branch wire. The still very diffuse region is there. So, but the vessel is very big. This is almost orifice. So orifice is okay. So inner lumen more than 3O. Okay. So now that we can dilate the 2.5. So after crossing the wire, so we can use the spotlight to reduce the radiation exposure.
12 だ。
Down. もうシングルプレーンでいいよ。
12。
よし、はい、じゃあ、はい、じゃあストアフローロ。何どうしたん？した？投資保存した？はいはいはいはい、もう一回どうぞ。
先生の足元でこうしようか
あ、そうだね。
な。12。
ちょっと前もあ、はいはいはいよいしょ、はい、14。
14。
あれなんか前出ない。あ、これか。はいはい、14。はい、リフレッシュ。はい。あら、いや飛んでないでしょ多分。拡張不十分じゃない。ちょっとラテからこっちから追ってみようよ。いくよ。拡張不十分なんだね。We cannot get the integrated flow, so I want to dilate the distal side by smaller balloon, 2 or something.どこからどこに入ってんの？
あ、移したから。10分でいいよ。
どの辺だろう。この辺か。この辺だな。多分。ちょっとあれをコーダールにして、これちゃう、これで見えてるのか。あ、でもこれで見えてるってことはどこ？あ、はい。
合わせるか
はいはい。これぐらいからでいいか。はい、どうぞ。4。
4です。
膨らんでる？ちょっと30秒ずつぐらいいく？もうちょっといくか。6。こっちもシーケンシャルに広げて、もしかしたら CTO のエンドまで広げれてなかったのかもしれない。さっきだいぶ手前にしといたから。ゆっくりゆっくり。はい、どうぞ。
4、6、
8、
8、
10。まあここはもういいやろ別に。はい。
はい。
いいよ。10。
10。
はい、じゃあ10。いいよ、リフレッシュ。ここはもう広げちゃってるから。 じゃあとりあえずここ。ほ
4まだまだ
よいしょよいしょよしじゃあ4 So now we dilated by the kissing balloon. So both balloon in the 2 off. Anyway, the distal to remain very diffuse region is there. So if possible, I don't want to put the stent today for the distal. So after balloon dilatation, we can see the very good flow from the antegrade. Yeah, we put the stent to the CTO segment and then finish the case. Okay, down. この PD のバルーンはステンティングに使うかもしれないからアンカーで。とにかく一旦抜いてこっちが 2.5 だよね。
違う、そうです。
そっちは残す。
これ長い。
はい。じゃあちらって取ろうよ。取らなきゃ分かんないんだから。血圧がちょっと低いな。はい、ちらっと見して。はい、行くよ。
はい。
ああ、いいじゃん。
ちょっと真っ白飛んだんですかね。
うん、ちょっと飛んで、でも、でもまあいい感じになったじゃん。So okay. So now we can see the some ST elevation in V2, 3, 4. So I checked the left coronary system by the 6 French guiding catheter. ちょっと next please. So in the angiogram, so LAD and the circumflex is okay. So left coronary system is fine. But still, gradually the EKG changed. It's better now. But still, we can see some ST elevation in the V2 and the V3. Maybe some distal embolization after balloon dilatation. So in the IVAS findings, we can see the very big vessel and so much plaque, and in some part with the attenuation plaque there. So that meaning the higher risk of the distal embolization after ballooning. So in this kind of the case, I don't want to put the stent aggressively. Maybe the smaller one is safer to maintain the TIMI3 flow and to make it the space for recanalization of the CTO. So now I want to I want to put the wire to the RV branch again, and then try to put the stent for the CTO segment. ほら、この辺だよね。はい、行こう。ゆっくり。1、2。
じゃあ3の40の後ろね。
3、4、5、6、
6、
7、8、9、10。3分。Now I put the 3 or 40 stents. I'm afraid the distal embolization after stenting, so stenting pressure is very not so much, so just a 10.
ちょうどいいくらい。
And I want to dilate it a very longer, so the 2 minutes or 3 minutes dilated. リフレッシュよ。まあ大丈夫っぽいな。ステントモードで撮影したら見えるかな、お城でも。あ、見えるな、お城も。やるね。So this stent is a very thin stent. So the strut is Oshiro is stent strut is thickness is very thin. And Alphenix has a stent mode. In the angiogram, we can see the stent struts very clearly, even though this kind of the very thinner stent. So now, あ、じゃあもうこっちじゃない。あ、リフレッシュして、ごめん。うん。Now we put the balloon almost proximal edge of the first stents. いらん。We checked the position in the stent mode. Maybe overlap is enough. It's okay, right? Then let's check the angiogram, right? Right. Gently, please. But anyway, we need to the additional 2 stents. So anyway, we can put the 3.5 stent for the proximal, the 3.5 by 40 millimeter, right? The Oshiro 3.5 40, please. あ、アンカーせな無理や。アンカーするよ。ちょっと待って。どっちが？こっちだ。4。
4。アンカー。
じゃあほい、アンカー引っ張って。いいよ。ちょっとまだ早い。ポジションはいいよね。オーバーラップしてるよね。そしたらジェイルドに変えるから。So I use the jailed button for the side branch. Just 4 atoms dilated during the stenting. So overlap is also fine, so that we can dilate. Okay? いいよね。あ、そう？じゃあもうこれでも PD のワイヤー抜いちゃおうか。抜けなくなったら困るし。これぐらい。そうだね。これ RO で見てみる？オーバーラップは完全にしてるよね。OK。じゃあ行こう。はい、置いて。1、2、3、4。3、4、5、6、7、8、9、10、11、12。じゃあ2分ぐらい。うん、変えよう。 OK。はい、行こう。しっかり取って。いいじゃん。うわ、何あいつ。ステントディスタルだな。ステントじゃあないか。ステント。
抑えますか。
プロラプスだろうな。まあ、アイバスで見てみようよ。とりあえずデフレして、これ。あ、これだ。はい。はいはい、いくよ。これだ。ドア。いや、これ以上やったらもうどんどん悪いこと起きるから。この辺ちょっと拡張不良があるんだ。ああ、ジェルドバルのとこだな。ああ、じゃあそれは広げればいい。ああ、まあ手前は OK だね。よし。外に出るんか、こんなん。そうだね。3.5 やりすぎじゃない？うん。3で相当ロングインフレーションしよう。この辺だね。この辺？待って、この辺な。はい。6。ゆっくり6。8。Okay, after standing, we can see the very big protrusion inside of the distal stents. So I checked the IVUS. We can in the IVUS findings also that we can see the protrusion outside from outside the stents. So now we dilated the 3O balloon by 8, almost nominal pressure. The long inflation. So after long inflation, the flow is fine. But today I want to finish this case. And after 2 or 3 months later, we checked the earlier follow-up CAZ and check the status. If we need to the more interventional strategy, we dilated, we stented for the distal side of the RCA. But if we use the aggressive balloon dilatation today, so embolization of the risk is higher and higher. Right?
ステントないですね。
ステントないだよね。
はい。
じゃあ広げるか。
はい、つきます。
1、2。
それはね、コントロールできる。
あ、いたいた。6、7、8。この辺から。まあ大丈夫じゃない？これアルベルランチでしょ。まあ許される範疇だからもうやめよう。あんまりやると次また別のことが起きる。とりあえず、ちょっと手前は細いけどこれはもう置いとこう。Okay, now we can move to the final shot. ちょっと見せて。OK。いくよ。しっかりとってね。
はい。
まあよくない？この枝か。ちっちゃいのはいるけどな。 So this is the final shot of the case. So in the distal stance, now we can see the small protrusion still now. But the flow is okay. Every branch, distal branch is patent. So today I want to finish this case. And maybe the earlier follow-up CAG will be needed for this patient to check the stenosis and the protrusion side, to evaluate the protrusion side. Okay. Maybe the distal is a very diffuse region that we can see, but usually after recanalized proximal side, the pressure is growing up. So after a few months later, we can see the very good big vessel, PD and the AB branch. I think so. So thank you very much. So I finished the case. Okay, thank you very much today. I want to summarize this case. So this case is the mid RCA CTO. So I started from the antegrade approach. So this shot is a bilateral shot. So from antegrade, we use the chip injection by Caravel. And also you can see the retrograde system by SPB catheter. So I started from the antegrade approach using by the XTA, but the XTA could not penetrate the proximal cap of the CTO. So I escalated to the Gaia next one. So after penetration of the proximal cap, I stepped down to the XTA again. But the inside of the CTO, XTA didn't work well. So I escalated the wire to the polymer jacket 3 gram wire Gradius. Because this kind of the long CTO, Gaia cannot be controlled appropriately. So that means I can make it a wire perforation very easily. So I avoid to use the Gaia for this situation. I use the Gradius for track the inside of the vessel. So even the Gradius, so wire control is not easy, but gradually Gradius can be advanced inside the CTO. So finally, the chip of the Gradius achieved to the most distal of the CTO side. So this is a contralateral shot. So we can see some collateral filling around the distal cap of the CTO, but I could not see clearly distal end of the CTO. So that means maybe the distal end of the CTO is not so hard. So I continued to the penetrate by the Gradius. So of course, in this situation, so retrograde is also a very good option. So, but anyway, antegrade preparation is needed for this situation. So I advanced the Gradius a little bit more. But fortunately, the Gradius could get the distal to lumen like this. So I put the microcaster Corsair to the end of the CTO and change to the wire from the Gradius to the XTR. Okay, XTR could get the AV branch. So like this. I checked the chip injection in the AV branch. So I put a small balloon, 1.5, and then try to check the IBUS. So in the IBUS findings, vessel is very big, and also in some part we can see the attenuation plaque. That means the plaque is very much. So I'm afraid the distal embolization for this kind of the case. And also to reduce the radiation exposure, I use the spotlight like this. You can see the small square in the angiogram. The inside of the small angiogram, so we can see the balloon and the wire clearly. But we put the filter in the FPD, so the outside of the square, the radiation dose is very low. And also we changing the radiation projection by bilateral approach, so to reduce the hot spot of the radiation dose. So upper side, this is a skin dose tracking system of the Alphenix. So you can see the blue area and the green area, and the yellow and red. So red area is higher radiation dose, but I want to reduce to make it a hot spot, red area. So that I changed the projection, angiographic projection, so many times to reduce the radiation exposure for patient's skin. So after balloon dilatation, so I put the 2 stents gently. The first one is a Oshiro 3040. So this is a Oshiro 3040 to the distal RCA CTO side. And then after dilatation, so we put another stent to the proximal side. The Oshiro, the strut thickness is very thin. So that means the visibility of the angiogram is very less. So the usual setting is that we cannot see the stent strut is clearly. But in Alphenix, that has a very good stent mode. So we can check the stent overlap with the stent mode angiogram like this. So even though the Oshiro stent, so we can see the distal stent very clearly, and then we can put the stent very appropriate position. So after put the stents, very good antegrade flow. Of course, it's a distal side of the CTO, very long diffuse regions there. But today, so we can get good chemistry flow to the distal. So that I finished the case of today. Thank you very much for your attention.
Canon Medical. Made for life.